Now I'll be talking about the evidence-based practice precision medicine. First, I want to start off with the genome-wide associated studies. They analyzed genomic data on a sample of 40,000 bipolar patients and replicated the discoveries of previous studies regarding several single nucleotide polymorphisms statistically associated with the disease, including the variants within the genes that I have listed. CACNA1C, ANK3, MAD101, and SYNE1. Genetic markers promise to be valuable at the earliest stages of bipolar disorder, as the main aim of mental health approaches at risk in early stages is to predict disease vulnerability and make accurate diagnosis. So far, though, little of the advances in genomics have translated into clinically useful tools. The International Consortium of Lithium Genetics have worked to disentangle genetic variants associated with treatment response, mainly response to the mood stabilizer lithium, which is the first line of treatment for bipolar patients. In 2016, the International Consortium on Lithium Genetics phenotyped 2,563 bipolar patients and reported a genome-wide association with a locus of 4 linked single nucleotide polymorphisms on chromosome 21 with lithium response. So hepatic cytochrome P450 genetic polymorphisms can be helpful in the future to predict tolerability and side effects of psychiatric treatments. Another useful tool for response is neuroimaging. It's useful to monitor treatment response as well. There was a preliminary study using a voxel-based morphometry pattern classification approach, was able to distinguish between patients with unipolar and bipolar depression based on structural gray matter differences in the brain. Studies on biological markers have suggested that peripheral concentration of brain-derived neurotrophic factor could be used to discriminate unipolar and bipolar depression, but evidence is still not clear. This would be the most importance in the earliest stages of the disease, considering that bipolar is often misdiagnosed since the index episode is frequently depressive. In consequence, patients are treated with antidepressants, and the introduction of a mood stabilizer is delayed until the first manic episode is detected, which may negatively affect illness course and prognosis.